हाँ। Hi, Dr. Neha. Shall we start?
Yeah, sure, we can start.
Okay, ma'am. I'll just introduce you to our doctors from Africa.
Sure.
Good evening, everyone. Welcome to today's webinar. We are delighted to have all of you here for this session. It is my pleasure to introduce our distinguished speaker, Dr. Neha. She's a senior consultant at Fortis Hospital. She has over 10 years of experience and specializes in infectious diseases, including COVID-19, tuberculosis, HIV, tropical infections, transplant related infections, and complex fungal and surgical site infections. Dr. Neha, we truly appreciate you taking the time to share your expertise with us today. We also have a translator with us. His name is Yaobi. He'll be helping our doctors from DRC follow along smoothly because they speak French. So, Dr. Neha, as you speak, please kindly take a pause occasionally to allow the translator to convey your message accurately. So, without further ado, we'll begin. Dr. Neha, over to you.
Thank you, Supriya. Thank you, Jivo Healthcare, first of all, that to give us a platform to collaborate internationally. You see, infections, when we talk about fever, when we talk about, one thing is very important, they are always across borders. They never differentiate between nationality, international. They can happen anywhere. Of course, the epidemiology, their patient and host factor profile, ethnicity does vary. So, today I'm going to talk about two important infections which are very important from three, four perspectives. Number one, their communicability, because they can communicate, they can transmit from one to another. Second thing, varied presentation. So, I can tell you about these two infections. Specifically, I'm talking about tuberculosis, can present in any form. Anything in our body, any differentials of any disease and syndrome, tuberculosis is one important differential. Regarding HIV, the lesser viral is the virus itself, more viral are the myths, more viral are different prohibitions, inhibitions, and lot of confusions regarding the therapeutics. Even though today in 2025, when we talk about these days also, when the patients come, they always have this question mark: can I lead a normal life? Am I being AIDS? Is HIV AIDS same or not? HIV in pregnancy. And with so many landmark studies and trials in terms of pre exposure and post exposure prophylaxis, the whole landscape of HIV therapy has become very, very robust and very efficient. So I'll just share my slides so that it can be visible to everyone. Hope they are visible to all. Can you
Yes,
see
yes.
my screen?
Yes, doctor.
All right. So as I mentioned that I'm going to talk about the tuberculosis and HIV, I would prefer, because I have made few cases and the case-based scenarios, since all of you are the primarily and the prime and key important health physicians to which the first time one person or a patient encounter. So, for all of us, it is very important to brush up, to revise our knowledge. I'm sure you guys are already well aware of these protocols. But today's idea was to interact with you people and to understand that what should be the approach in different kind of settings, uncommon presentations of one or two common diseases. So
Étant
when I
donné que vous êtes tous des experts dans vos domaines, nous allons, au cours de cette présentation, toucher des cas d'études pour avoir les points de vue de tout un chacun par rapport à la méthode à adopter.
So this will be the content and the flow. We know that tuberculosis and HIV, and why they are called as double trouble, because one presence leads to the risk factor of the other, and one infection increases the frequency of the other one. I meant, if you have a tuberculosis, one of us has a tuberculosis, the existing percentage of having the HIV increases, rather, I would say doubles. And vice versa, if one has an HIV, presence of tuberculosis in the different form and drug resistance also increases.
Nous allons parler de deux maladies, à savoir la tuberculose et le sida. La raison pour laquelle c'est que ces deux virus sont interconnectés et une personne qui souffre de l'un des deux a plus de chances de contracter l'autre.
So I'll just start with the perspective that we need to first understand that HIV infection is categorized into two forms, depend upon when the patient enters into your OPD. So it can have a acute, immediate presentation, which almost looks like a acute viral infection, something like a flu virus, high fever, sore throat, cough, cold, and some lymph nodes, overall very weak. Whereas the chronic infection, which is not treated, that leads to something called as the advanced HIV infection, advanced immunodeficiency syndrome. So, very important message from this slide is that having an HIV infection is not equivalent to AIDS. And this is a one very important step when we counsel such patients to begin the ART is presence of today's ART, whenever in the time you are diagnosed with HIV, limits and halts the progression into AIDS.
Il est essentiel de comprendre qu'il y a une différence entre le VIH et le sida. Le VIH est un virus, tandis que le sida est un syndrome résultant de l'infection par le VIH qui n'a pas été traité. Et cette distinction permet de réduire la stigmatisation et aussi d'assurer une éducation efficace des patients.
So, this is about the global HIV statistics. We know that globally, worldwide, around 84.2 million people become infected with the HIV. On an average, roughly 1/4 of those individuals I have access to any kind of ART therapy. And amongst those individuals, 1.5 million of all 84 million have died because of AIDS related illness. So now there is a concept of people living with HIV. And that is the whole goal of the HIV directed therapy, that maximum people, and these days there is a rule of 90 90 90. That means 90% of the people are aware of their HIV status. Of them, 90% of the people have access to the HIV therapy, and of them, 90% of the people should be taking the HIV therapy with the compliance. If you see on the right side, this is a global statistics with the dense aggregation of maximum of HIV bar retropositive people coming from the Southeast Asian African and certain numbers with the Eastern and Southern Africa. So the majority of the two continents being involved is this Asian and African continent. If I further break, 10 countries which account for nearly half of a new onset HIV infection, African continents and country rise high, compare and followed by Indian settings as well. So if you see, it's a major problem in our settings and we need to know how to go about it.
Nous pouvons voir sur ces statistiques les personnes affectées, les personnes décédées et les personnes qui ont un impact du VIH sur leur vie. Et le nouveau programme qui est en vigueur actuellement, c'est celui de permettre aux gens de vivre avec ce virus. Et il y a la fameuse règle des 90% qui veut qu'au moins 90% des personnes touchées soient diagnostiquées, au moins 90% d'entre eux puissent prendre connaissance de l'existence des traitements pour pouvoir vivre avec la maladie et au moins 90% puissent prendre ces traitements-là. Et nous pouvons voir sur le graphique d'à côté les pays les plus touchés par le virus. Et nous pouvons remarquer que l'Asie du Sud et l'Afrique sont essentiellement les zones les plus touchées.
Moving ahead, I'll just start with one case scenario, and this is a routine case which lands up into our OPD. A 24-year-old sexually active male with multiple partners, fever, lymphadenopathy, and a generalized rash. So, what are the common thoughts? What are the common differentials in our mind? Usually, it comes with the first thought that it's some kind of viral infection, some kind of streptococcal throat infection, something related to any allergic bar, any reactionary issue, and of course, a very important symptom and should not be neglected in the differential is the HIV. So, when we suspect HIV, we should have a clinical background and, of course, some most of the time an epidemiological link. So, a young male, multiple partners with this kind of syndrome, which is usually a scenario with acute HIV syndrome. So, what are the tests? How will we diagnose? I'll just show in this slide that there are the different kind of tests for the HIV, and we need to know when to order what, and that is a very very important characteristic and a limiting factor. So we should be able to understand whenever an HIV infection enters the body, first 14 days practically we are never able to detect that whether the HIV infection has entered the body or not. And the first test to be picked up is the viral load. That is how the virus is multiplying. This is the PCR, that is a polymerase chain reaction, which detects the viral copy number. And that can be used as early as the second week. So infection starts after 2 weeks. The first test to pick up is the viral load, viral PCR. After the second week, roughly from second to third week onwards, because the virus starts multiplying, it releases its antigen, which is called as the P24 antigen. So first, this is detected, followed by this detection, which is in the form of blood test antigen. But it only remains in the blood for 2 weeks. So 2 to 4 weeks, this antigen can be picked up. After 4 weeks, when your immunity response starts happening, then we detect the antibody against the HIV through these number of tests. So just to remember, in the order, first test after 2 weeks of infection is this, followed by this from 2 to 4 weeks, and after 4 weeks is the antibody test.
Nous prenons le cas d'étude d'un jeune homme sexuellement actif avec plusieurs partenaires qui présente des signes. Et pour ce faire, nous devons conduire des tests qui nous permettront de savoir si la personne a le virus et de savoir les étapes du traitement à suivre.
Right. So when we have ordered an array of tests, so ideally, again, one very important thing is many of times we come up with the scenario that the person comes into your OPD, show us one test that I am HIV positive. Can I label it as an HIV positive? No. So the scenario says based on what kind of clinical settings the patient is. So usually in the clinical settings, there are two thoughts. One, either the patient is symptomatic, or second, patient is asymptomatic. So when I say symptomatic, either they come up with lot of fever, infection, other opportunistic infection, something like tuberculosis, I'm going to discuss that, some kind of fungal infection. And the second scenario is that the person has a sexual history of exposure and they want to test for the HIV, and they have tested for HIV and they found out to be positive. So in both the scenarios, ideally, you need three different tests. As I shown in these generation of the antibody test, you need three such tests of HIV 1 and 2 respectively, and combination of all three positive. That means first test reactive, second test reactive, and third test also reactive. Then only you label someone as an HIV positive. So make sure whenever you see a patient and they come with the test, ensure that three type of different tests That 3 different tests can be different in the form of type of the testing, means ELISA or CART test or comb test, or they can be different in the form of what antigen you are testing. So the combination of 3, either 3 positive, 2 positive strong plus 1 intermediate, these two only conditions lead to the diagnosis of HIV. As you can see in the slide, plus, 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 and minus. So the 2 test plus and 1 indeterminate, then you get the viral load as a confirmation. If it's positive, diagnosed. If it is also negative, then you say it's negative. If you have all the 3 tests, suppose 1 plus 1 plus 1, all 3 positive, then you don't need to proceed with this test and it can be automatically positive.
Nous devons toujours suivre un protocole de diagnostic du VIH parce qu'il y a la nécessité d'avoir des méthodes standardisées pour comprendre l'état de santé des patients et aussi leur activité sexuelle non protégée. Et pour chaque diagnostic, nous devons nous assurer qu'il y ait au moins 3 tests différents qui a été fait et nous ne pouvons déclarer la personne séropositive que si ces 3 tests sont sortis positifs ou 2 sont sortis positifs et 1 est moyen.
Right. So now I'll give you another case scenario. So you diagnosed that patient as positive. Now the CD4 count. So you see, a very important thing is when we start someone on the HIV therapy, there should be 2 goals of therapy. I always say my patient. 1, viral load should be minimum, and CD4 count, that is your immunity levels, that is your CD4 lymphocyte count, should be higher and higher. That is the only objective goal of the entire ART therapy. Now, suppose this gentleman has found out to be HIV positive in 2013. That time, the CD4 count of the husband was 330. And of course, the wife was also came out to be positive because there has been uninterrupted exposure before he got diagnosed. Husband was started with the old therapy in 2013, which was zidovudine, lamivudine, and nevirapine based regime. Whereas in 2013, wife was kept under the routine follow-up because that time there were the guidelines that based on your CD4 ratio, then we will only decide whether to treat or not to treat. But now her CD4 count is 670. That has been dropped because initially it was 960. Now it has dropped to 670. So should she be started on ART? What are the classes of ART available? What drugs will you start? And any other additive advice. So it's a routine case. A lady lands up into your OPD. Her husband is already on an old ART regime and he is happily satisfied with that regime. His viral load is under control. Wife says, I have been diagnosed for almost 12 years, but previously I was not given any ART option. Now, it's a very important to know that these days, since 2015, and after 2 years later, even India has adopted that strategy that treat everyone. Irrespective of any kind of CD4, we are supposed to treat HIV infection at every aspect. So the answer to first one is actually that we should be starting her on the ART therapy. As far as the antiretroviral therapy is considered, this is a good diagram just to summarize that what are the common classes of drugs which are available. So for that, we need to understand the cycle of the HIV. This is how the HIV virus enters the body. That is your receptors. Then it enters into the cell wall, enters into the mitochondria. With the help of the reverse transcriptase enzyme, the viral DNA enters into the nucleus. This is our nucleus. This is our human DNA. There, that virus integrates with our own human DNA and mutates it in such a way to form the next line of generation of its own RNA. So DNA breaks into two arms, enter into the nucleus, integrate with the host DNA, and then forms the progeny of the viral RNA. These RNA are nothing but the pre-packaging proteins. Then they form the mature proteins, which forms the mature virus particle. Then it breaks the wall of the cell and then releases into the system to infect the other cell. And this cycle continues. Now, I have just highlighted at every step. At the entry, we have nowadays a drugs called entry inhibitors. I'm sure you guys have heard about lenacapavir. That is a recent drug. I will share the things with you later. But lenacapavir is known to cause the entry inhibition. You stop the entry of the HIV virus from the step one. Second comes that it has entered, but now you're stopping the replication and entering into the nucleus. So all current strategies of nucleoside inhibitors work on this. Then integrase, when it is about to integrate into the host genome, that part can be blocked by integrase inhibitors, that is dolutegravir, raltegravir. And because it's a very crucial step, these class of drugs has a very good role in the overall efficacy of ART. And then the last step is when they move out to infect the other cell, that exit also can be inhibited by the group of drugs called protease inhibitors.
Là, nous explorons la dynamique de traitement en nous focalisant plus sur le traitement d'un couple séropositif en tenant compte les récentes évaluations de santé de chacun. Et la nouvelle consigne qui prévaut actuellement, c'est de traiter quel que soit le cas de l'un ou de l'autre des partenaires. Il faut toujours traiter dans le doute. Et nous voyons ici sur cette image les différents types de traitement à donner en fonction de l'étape à laquelle se trouve l'infection.
Right. Now, as I mentioned, that the wife has come up, CD4 count is 670. So should we start her on ART? Yes, we need to start her on ART. What are the classes? I have just shown in the previous diagram. What are the common drugs which we start with this patient? So there are triple drug regime therapy in the HIV, which is a heart and soul of HIV therapy. Gone back are those days which were older nucleoside based regimes like zidovudine, nevirapine. Now, then came the era of nucleotide inhibitors, something like tenofovir, something like efavirenz. Then come the integrase based inhibitors. So nowadays, the triple drug therapy, usually the best triple drug therapy is combined with one integrase inhibitor and two nucleotide reverse transcriptase inhibitors. That is, two NRTI plus one integrase inhibitor. And the commonest ones which are available in our settings is tenofovir
You put another. Actually, put the.
I am extremely sorry for that technical glitch. I think there was some power connector issue. Sorry, I was here. I'm extremely sorry. So, as I was discussing, that the major backbone of the therapy is the triple drug therapy, which includes the nucleotide based plus integrase based regime. So, commonly available in our Asian African settings are the tenofovir alfenamide, lamivudine, emtricitabine. These three, in the terms of nucleotide combination, and dolutegravir, bictegravir in terms of integrase-based regime. So permutation and combination of these two arms makes one single pill these days to take care of the ART therapy, which will be once a day at any given time of the day. Not much food interaction is there, and you have to continue taking it as around 18 to 24 hours. And what about the other things is nowadays entire game of ART is all about prevention. So when we know that HIV does not cause any direct hit, it decreases the immunity and causes the increased risk of infection. So all thing boils down to reducing the viral load through the help of ART and preventing the infection to happen in the form of tuberculosis preventive therapy, vaccination like you do in any other immunocompromised setting.
Yaomi, you can translate.
Revenant sur le cas du traitement du couple dont nous parlions plus tôt et surtout sur celle de la dame, est-ce qu'il faudra recommander le traitement antirétroviral dans ce cas? Oui, et nous recommandons aussi surtout le triple traitement et nous avons des traitements que nous avons montrés dans le slide précédent. Et il faut noter aussi que ces traitements sont disponibles dans nos régions, à savoir l'Asie du Sud et l'Afrique.
Right. So this is what I was mentioning too. And then the newer approaches have also come. Nowadays, even beyond the pill therapy, there is a availability of longer acting ART regime. And what is the best part about these longer acting regime is that you don't have to take a daily pill. 3 months, one injection, and you are sorted. Then there is also an advancement that instead of 3 drug therapy, a 2 drug therapy, because lesser is the number of drugs, better is the simplification of the treatment, cost saving is also there, decreased adverse effects are also there. So the whole paradigm of ART has now changed, and it is to get more and more easy usage, user friendly, lesser side effects, and even lesser drug interaction. Because with the good long life now, recently one of my 104-year-old HIV patient came to the OPT with his birthday cake in the hand. It feels so relieved and so happy to see such a long life now with the HIV, thanks to these therapies.
Là, ça a mis cette fois-ci un peu plus sur les innovations en cours et les nouvelles voies thérapeutiques dans la gestion du VIH, mettant en évidence l'évolution du paysage et des options thérapeutiques. Et l'objectif est de réduire le nombre de prises à avoir pour ne pas avoir à prendre des traitements chaque jour, mais peut-être par trimestre et aussi réduire le coût pour les patients.
Right. Now, when we think about the therapy, we need to know that how to go ahead with the therapy. So it's not just about the virus, the efficacy. You have to treat a person. You're not treating a virus. You're not treating just to kill the virus and increase the CD4. I tell you, the problems in starting the ART is not about the regime. The problems are when you have a lot of other issues. So, for example, this is my recent case, which I have took from my OPD almost 3 months back. So she was a 52-year-old female. She is asymptomatic. Her husband was positive for HIV. Unfortunately, the husband expired a year back due to some cardiac complications. That lady was suffering from osteopenia. Of course, she is 52, postmenopausal, osteopenia, osteoporosis. She is a known asthmatic. She used to take budesonide inhalers for almost, I don't even remember, she said 14, 15 years altogether. She is a hypertensive female and she was a relatively obese female. These parameters on the right side were her labs. HB of 9.9, platelet count of 1.7 lakh, CD4 count of 398, viral copy number was relatively higher, and the other parameters of VDRL, HBS, and anti-HCV negative. So, when we deal with such patients, we need to also understand that it is not only about the viral. We also need to understand their levels, their CD4, their age. See, ideally, when we talk about tenofovir TDF, that is tenofovir disprovoxil, it was a beautiful drug, but it suffered from the major two side effects: osteoporosis, loss of bone density, and kidney function disturbance. Now, with this female, which is already at the verge of being osteoporotic, because of hypertension, obesity, her kidneys are already at a high risk. It's very difficult to combine that kind of regime. So, idea to put this slide was to make you understand that with more longevity, we need to understand different perspective and taking a patient as a whole, that whether that patient is a diabetic, hypertensive, kidney patient, psychiatric illness, very important, because a lot of antipsychotic medication have a drug-drug interaction with lot of ARTs. Neurologic disturbance, Parkinsonism, dementia. So that is very important to construct a regime that pill number. You should make understand that even though you can have a one pill number, increasing up to two also creates a problem for a patient because they are already having a list of so many medicines. Once a day versus twice a day dosing, food requirements, their own genetic barrier of resistance. So these are very important indications to make a regime.
Il est important de noter que nous traitons un patient et non le virus. Donc, il faut prendre en considération l'état du patient, que ce soit ses conditions sanitaires, son âge, si la personne a d'autres maladies et d'autres effets qui pourraient avoir des répercussions négatives par rapport à un traitement spécifique. Donc, toutes ces conditions mises ensemble doivent nous permettre de suggérer le régime la personne puisse non seulement être traitée de ce virus, mais ne pas contracter aussi d'autres maladies ou bien d'autres dysfonctionnements, d'autres effets secondaires en prenant ce traitement.
Right. Now, coming to the next scenario. So we have made a regime, a good regime. We have started that patient on ART. We told them the risk factors and very important factor. So I tell you, with HIV, amount of medical counseling is less, but amount of social counseling becomes a very important, because considering this HIV infection, its related myths, they are very, very much there regarding, can I eat from the same plate? Can we sit together in the same room? Am I going to pass to my kid, just like sitting with them and sharing food with them? What about my wife? What about my husband? So very important pertinent thing to talk about it is that how it gets transmitted or infected. The major two routes still being there as a unprotected sexual intercourse, and blood products transfusion. Even I request all the male patients, if you put them on the ART, if their viral load is quite high, usage of the common razors, blades, and the other products which require a skin contact, that has to be avoided in the sharing basis. And it's a very important dictum, which is 2024 theme also. U is equal to U. Undetectable is equal to untransmissible. So whenever a young people come and they are about to get married, they are just being married, starting their family life, a very strange and a very scary question comes from them is that how will I lead our normal lives? So we always say that unless and until you are not detectable, you can have a normalcy in your married life. But for that initial period of getting a viral load up to the undetectable mark remains the standstill of choice. And then the question comes how to hold those young people, how to hold anyone for that matter, from achieving the normalcy in their physical and mental routine. So there comes the question that an HIV negative young female marries to an HIV positive male who is on ART. Now they have their own risks and concerns. The lady comes and asks that, am I eligible for a pre-exposure prophylaxis? Should I take that forward? What will be the advice to them, to these kind of discordant couple, when one couple of one partner is positive, whereas the other is the negative? So answer that, there is a concept now of a pre-exposure prophylaxis. That means if one has a HIV, the other person who is in a close sexual contact with that person can take this pre-exposure prophylaxis to reduce the risk of acquiring that HIV infection from that person. Definitely, it is prescribed for the HIV negative adults, but those who are at the higher risk of acquiring the HIV.
Nous mettons l'accent sur le fait que le traitement antirétroviral a plus d'impact sur le volet mental que sur le volet du traitement en lui-même, à cause des stigmatisations que rencontrent les personnes qui souffrent de ce mal. Et nous mettons l'accent aussi sur le traitement de la prophylaxie pré-exposition qui est plus recommandé pour les partenaires séronégatifs qui ont des partenaires séropositifs. Et ce traitement est recommandé pour éviter la transmission quand on est en face de deux partenaires qui sont dans une activité sexuelle régulière.
Right. So how does the PrEP work and in what kind of individuals? So if you have the people which are coming to your OPD, which are men having sex with men, that is the homosexual, heterosexual females, of course, heterosexual male, and even the injectable drug users. Because these are the four categories of people who are at the high risk of contracting the HIV from their known or unknown partners. So this is the order that how they will work, and efficacy of using a pre-exposure prophylaxis is pretty good. It ranges from 75% to even 99% based on how compliant you are, what are the occasions which you are taking it. So it is very effective in reducing the risk of HIV infection.
Les résultats du traitement de prophylaxie pré-exposition sont assez encourageants, surtout dans des catégories les plus exposées, les homosexuels, les femmes hétérosexuelles, les hommes hétérosexuels et ceux qui utilisent des injections à la seringue. Donc, nous voyons ici les pourcentages de taux de réussite dans ces différentes catégories de personnes.
So this is about the actual effectiveness of PrEP. And as I mentioned, if you have, I just want to highlight that if you have the effectiveness, that is all dependent upon the adherence. So I'll just read the one important line here is, if the adherence, can we mute the background noises?
Yes, yes.
Yeah. Thank you. So if the adherence is more than 90%, there is a significant reduction in the risk acquisition of HIV, which is roughly 73% self-reported and 92% reduction if you are taking it all away in a nice way. So, which is a major breakthrough in the HIV prevention, because it's not only about reacting, it is also sometimes about action in the right way and at the right time.
Nous remarquons selon les statistiques que le plus on suit les recommandations du traitement par la prophylaxie pré-exposition, le plus le taux d'infection de ce genre de partenaires diminue. Donc, il est important de bien suivre ces recommandations.
So, this is on the daily oral pill, days from which when the protective levels are achieved. So, if the recipient is having the anal sex, it's almost a week. Vaginal sex after 3 weeks. Injectable usages, 21 days. So, roughly in a week to 3 weeks' time, that level of the efficacy for a drug to prevent almost 75% of the risk of acquiring HIV usually achieves.
Le délai de réussite du traitement traitement pré-exposition va de 7 à 21 jours. Donc, dans ce délai-là, la personne qui prend ce traitement régulièrement pourra être assez immunisée pour éviter la transmission.
Then there's a very interesting concept, and I wanted to share with you all that nowadays even on-demand preps are available. So many a times there are young people and there are people who are in a party place and they had a unprovoked exposure or an encounter with some unknown or a known person. And then they have a very scary thought in their mind and they lands up into ROPD that now to do what next to do. So in that scenario, there is an on-demand prep which is there. So those who can have like a, infrequent sex, like less than 2 per week, or they have something in the thought that they are going to meet someone and they will land up in hooking with each other. So in that scenario, this 3-pill concept, 3-time concept of total 4 pills has been arrived for these people. But I would just have a caution for this, that repeated instances doesn't mean it's every time more than 90% efficacy. Because since it's a shorter acting, it is only to prevent the incubation of the virus at all to happen. But at a point of time, if you're doing it very early and a very frequent, there are high chances of development of the drug resistance. So you should still stick to the personal protective regime in terms of the protective condoms and the protective vaginals. But this can come as an easy way, as an event-driven prep for someone who is asking you for the same.
Donc, nous voyons un peu la posologie à prendre sur ce genre de traitement et il est très important de suivre cette posologie et ne pas aller au-delà parce que si on en prend au-delà, la résistance du virus par rapport à ce médicament pourrait s'accroître et cela rendra le traitement inefficace.
So currently, the 2 drug regimes are approved for the pre-exposure prophylaxis. They are the combination of tenofovir disprovoxil or a tenofovir alfenamide, and along with that, the emtricitabine. So one is a TDF emtricitabine, another is a TAF emtricitabine. They're more or less matched in their efficacies with a little difference in their side effect profile, as I mentioned, that the TAF is free from the side effects of kidney and bone toxicity, but it causes a little lipid disturbances. So in terms of the obesity causing and a higher BMI occurring can be one of the side effects.
Là, on voit un peu les effets secondaires listés par rapport à ce traitement.
I have already discussed with you the eligibility. So I'll just skip this slide. And now there is also a path-breaking discovery which has happened in last year, which was lenacapavir based on the HIV prevention. So this was a very remarkable trial which was published in NEJM last year. As I mentioned in one of the life cycle, lenacapavir is a inhibitor of the HIV capsid formation. So that inhibits the replication of HIV in both the early stages and the later stages, being a dual inhibitor. So in that scenario, the risk of HIV acquisition based on this drug is negligible to even less than 2%. And with the help of a longer acting formulation, when used with this molecule, it allows the slow release of the drug using subcutaneous route, which provides a good drug level for almost 26 weeks. So this article has been evaluated as a preventive therapy, and they have shown that 6 months, one injection can lead to more than 92% of the prevention of HIV viral replication. So this was a study in that format where they have taken 5,000 plus adolescent girls and young women from South Africa and Ugandan region. They are sexually active with the male partners. They were not using any kind of PrEP. It was a phase 3 trial, and they have been seeing that the patients were either taking the lenacapavir or the oral drug formulations, which I have just mentioned in the previous slide. And to our surprise, and it was a wonderful result, that twice in a year, lenacapavir reduced the HIV incidence was almost 100%. And in the subset, it was mentioned 93%, which is almost remarkable as 100%, as compared with the other placebo arm. And in terms of the side effect profile, there was just injection site pain, which was just very mild and can be easily managed with some popping painkillers. So the monitoring of this kind of drug is very much needed, because if that is a scenario, 1 year, 2 injections, and one can lead a very good life with their partners in the term of both physical and mental disturbances posed by this disease.
Nous parlons spécifiquement du cas du lenacapavir, qui est un nouvel inhibiteur de la capside du VIH qui vient d'arriver sur le marché il y a un peu plus d'un an. Et nous expliquons sa double fonctionnalité dans le traitement, mais aussi la prévention du VIH. Et une étude a été faite sur des jeunes adolescentes sexuellement actives en Afrique du Sud et en Ouganda. Et on a vu que malgré qu'ils ne prennent pas d'autres types de traitements, la seule prise de lenacapavir réduit les risques de contraction du VIH de presque 100%. Le taux officiel qui est publié est de 93%, qui est presque aussi bon que 100%.
Now, another scenario is, this is all about the PrEP. You have seen so far a patient coming naive into your OPD, a patient who is coming with the previous history of acquiring but now wants to take the ART, a patient who is positive but the partner is negative. And now comes the scenario which we as a doctors face a quite while. That is a young resident who was sampling the blood from an HIV positive patient who was on ART for last 6 years, and the patient is taking tenofovir, lamivudine, and dolutegravir based regime. And that patient is admitted in our ward with the PCP pneumonia. So while taking a blood sample from that patient, a poor young resident gets pricked. The kid is already panicked, because obviously it's a huge social thought process and a stigma that now what? Because the entire things revolves around, have I contracted the HIV, whether I will get affected by it, what will be my future strategies, so what kind of post exposure prophylaxis will be there. So we need to understand that the HIV transmission risk amongst all is maximum by the blood transfusion. Perinatal and sexual intercourse still lies lesser as compared to that. So, most of the commonest cause when we talk in terms of route is definitely sexual intercourse. But the maximum chances of transmission of the HIV virus is through the blood and blood products. So this is one important notion, or I would say a misconception which we all have in our mind, that most common is not equivalent to the most highest risk. In that scenario, it is very important to understand what are the risky fluids: blood, semen, vaginal secretions, breast milk, CSF, and other body fluids. They are very considered as the higher risk.
Nous parlons cette fois-ci de l'importance de la prophylaxie post-exposition pour en soulignant aussi la nécessité d'une action rapide dans les délais spécifiques pour être efficace. Et nous devons corriger quelques misconceptions qu'on a par rapport à la transmission. Le plus courant est bien sûr par les rapports intimes. Mais le moyen le plus risqué est la transmission par le sang. Et nous voyons ainsi lister les différents types de transmission en fonction de leur risque.
Right. As far as the prescription is a point, the post-exposure prophylaxis should be started as soon as possible, because there will be a replication time and there will be an incubation time too. So ideally it should be started as soon as possible, and preferably not beyond 72 hours. But in the rarest of the circumstances, we did advocate the PEP even from third day to maximum 5 days, because sometimes the people do come late. But having said that, the maximum efficacy of the PEP is being defined not beyond the 72 hours. Many a times the people ask question that should I get the HIV report, and based on that the PEP can be started. So one very important point to highlight is PEP initiation should not be delayed at any cost, because presence of an HIV report at that time when you got the exposure is not gonna indicate the present exposure. As I told you previously, that usually it takes 2 weeks to 4 weeks to diagnose the HIV. So whatever baseline, so suppose you have a prick today, if you get the HIV testing today, that will indicate your previous or the recent exposure to the HIV within the last, say, 2 weeks to 4 weeks, which is the minimum time of detection. But it does not say that if you have got the prick yesterday, are you HIV positive or not? No. For that, you have to do that testing after 2 weeks or 4 weeks of exposure. But till then, you can't just wait and sit on hand. You have to start a PEP based on how far was the risk of exposure, what kind of patient was there. If it's a proven HIV positive, it's always better to start the PEP undoubtedly as soon as possible.
Il est important de commencer le traitement sur la prophylaxie post-exposition le plus rapidement possible. Nous donnons un délai de 72 heures maximum. Et il est aussi important de noter qu'il ne faut pas forcément attendre un résultat positif par rapport à l'exposition VIH avant de commencer le traitement post-exposition, parce que les tests ne soulignent pas forcément l'état actuel, mais l'état d'il y a 2 à 3 semaines. Donc, mieux vaut commencer ce traitement, même si on n'a pas la certitude d'avoir contracté le virus.
So most of the times the PEP includes the similar 3-drug profile which we give for usual ART therapy. So it will be a TDF or a TAF based regime plus emtricitabine plus one of the integrase inhibitor. Commonly available in our settings is dolutegravir. So usually the scenario is T plus E plus D. The combination of these three, which comes in a single pill, is advised for a post-exposure prophylaxis for approximately 28 days from the starting of the exposure. And after 28 days, the person is advised to follow up with the antibody testing.
Nous voyons ici lister le régime recommandé pour le traitement post-exposition, et nous voyons qu'il faut que ça combine ces 3 produits, et au-delà d'un délai de 20 jours, le traitement avec des anticorps est recommandé.
Now, last 2 scenarios in the HIV, we heard about the therapy, we heard about the complications, we heard about how to design a therapy and what to follow up. We also heard about the pre-exposure and a post-exposure prophylaxis. Another set of patients who come with at the first time mothers, those mothers who are expecting, when they found out to be in the first trimester that they are HIV positive on screening. Now, what next? What regime will you prescribe? Is baby requiring a prophylaxis at the birth? Should we breastfeed the baby? And how will you follow up the baby and exclude that there is any infection in him or her? So initially we used to say the PPT-CT, that is prevention of the perinatal transmission and contact tracing. But now recently that terminology has changed to EMT-CT, that is elimination of mother to child transmission of HIV. So usually mother, if she is taking good ART during the entire pregnancy, and with the good viral suppression, CD4 well achieved, first of all, the risk of transmission transplacental very much decreases. And you can still continue taking the same profile of the drugs there. Regarding the infant prophylaxis, if exposed, it's preferred to have a 6-week of nevirapine syrup-based regime as an infant prophylaxis. And as far as the diagnosis is considered, 6 weeks to 6 months of age, usually the dried blood spot is tested for the HIV PCR at 6 weeks, followed by the repeat testing. And if the child presents to you at more than 6 months of age, so we prefer it by doing the 3 serological tests that I mentioned you in the first slide, the antibody test, and further confirmation happens by doing the same HIV PCR testing.
Nous parlons maintenant du cas d'une femme enceinte qui se rend compte qu'elle est porteuse du virus. Comment faire pour éviter la transmission à son enfant? L'un des moyens efficaces, c'est de suivre le traitement antirétroviral pendant la grossesse et même au moment de l'allaitement, pendant les 3 premiers pendant le premier trimestre, après l'accouchement aussi. Et en ce qui concerne le diagnostic du nouveau-né, cela se fait entre 6 semaines et 6 mois après la naissance du nouveau-né.
So, as per the guidelines, if the ART naive mother is there, so we continued the same regime as I mentioned as a routine ART. So, mother on the ART who is not started yet, because there can be only 2 scenarios. A, mother was tested positive just at the beginning of the pregnancy, or the mother was already on the ART when she conceived. In both scenarios, the therapy remains almost similar. Breastfeeding, regarding that, usually there is no common consensus, but it is always said, as I mentioned, that breast is one of the high risk fluids being mentioned. So it's preferred that if the mother viral load suppressed, she can still breastfeed. But if the viral load of the mother is higher above 1,000 copies, it's preferred to have a top feeding or a replacement therapy rather than a breastfed. Neonatal prophylaxis is usually nevirapine-based regime for 6 weeks to 12 weeks. And as I mentioned in the previous slide, the neonatal testing is usually done by total nucleic acid or an HIV-based PCR regime, initially at the 3 weeks time, followed by the 4 months, and confirmation by further 6 months.
Durant l'allaitement, que ce soit que la femme enceinte soit sous traitement antirétroviral avant la grossesse ou pendant, il est important de continuer le traitement. Et en ce qui concerne l'allaitement, si la maman séropositive a une charge virale supérieure à 1000, mieux vaut recourir à d'autres méthodes plutôt que l'allaitement pour éviter les risques de transmission au nouveau-né.
Now, moving ahead, so all these were very good scenarios. You got the positivity, you gave the therapy, the patients are doing fine. But all things cannot be always goody. And you have to troubleshoot also sometimes. So again, this was a case which I encountered almost 5.5 months back. So there was a cricketer who was diagnosed as a retropositive infection 3 years back. And he was initially that time started with the TLE-based regime, that is tenofovir, lamivudine, and efavirenz. Now he landed up with the cough, fever, and even hemoptysis. When I asked him that, are you taking the drugs well? So he admitted the fact that he used to go for his cricket matches during the therapy sessions. So at times during the practice sessions, he used to miss his drugs on the several occasions. So there was a kind of a failure to the drug adherence. Now his CD4 count, which was at the previous baseline was 300, dropped to 98. And when I tested his sputum came out to be positive for Mycobacterium tuberculosis. And of course, I have to start him on the anti-tubercular therapy. So what is the next step now? So we need to understand that HIV and TB co-infection is a double trouble, as I started my thoughts with that. And it's a global huge burden. So if you talk about out of 1.1 million cases, so if you have in total 10 million cases of TB worldwide, 1/10 of the cases happens in the HIV positive individuals. Means it's a huge burden. And of them, 4 lakh deaths out of total 1.4 million deaths happens in HIV positive population. As I mentioned that HIV, because it breaches the entire barrier, mucosal barrier, increases the acquisition of the tuberculosis. And tuberculosis and HIV, there is a huge problem right from the disease, the clinical presentation, and even therapy, because, rifampicin and HIV drugs have a major drug-drug interaction. So it's a co-infection is always considered as a double trouble from these 3-4 aspects. And then important thing comes is, now this cricketer falls into the range of failure of the HIV therapy. Because there is a clinical failure, he acquired a WHO grade 3 clinical infection, that is pulmonary tuberculosis. His CD4 has fallen down to 50% of the base value. And then there is called as a virological failure. So I'm sure as you doctors, many of the scenarios we come across that the patient who was taking ART has landed up with the new onset infection, or sometimes even not with the infection, their CD4 count started falling. So then what should be done next? So the failure is prescribed in the 3 important things. A clinical failure when he or she lands up into the new infection, or even a cancerous disease as well. Immunological failure when the CD4 counts start falling, either 50% from the peak value, or the counts are not even increasing. At the beginning of the therapy, they were 90. At the 3 years of the therapy or 2 years of the therapy, they are still 90. And then comes a very important indicator to label completely as a failure is virological failure, which means that at least after taking 3 months or 6 months based on WHO and NACO category. So in our settings, we use a 6 months of therapy. In WHO, they say 3 months of therapy. So based on the ART, if in spite of taking ART for 6 months, the viral copy number doesn't fall below the significant number. I'm talking the patients who are already taking the ART, who were initially suppressed viral load first time, but then they constantly causing the increase in the viral load.
Nous allons commencer par le cas d'un joueur de cricket qui était sous traitement et qui ne suivait pas les indications, ce qui a amené une aggravation de l'état et une implication aussi de la tuberculose. Et comme on le précisait au début, la tuberculose et le VIH sont 2 infections liées et avoir l'un augmente les risques d'avoir l'autre. Et nous allons suggérer un suivi assez poussé des consignes de traitement pour éviter d'aboutir à des situations d'échec de traitement et comment faire le suivi de ce genre de traitement.
So then what should be the testing of that? So who should be testing? If they have a virological failure or their RNA levels are above 1,000 copies, when we should test them? When they are on the failing regime in terms of clinical failure and immunological failure. Unfortunately, many of our centers are not well equipped with the HIV resistance testing. Though ideal scenario is nowadays when we start the therapy or when you see the failing therapy, it's always preferred to have a genotypic testing. But having said that, it is a difficult task to achieve. So we still stick to the practical formulations that if the viral load is also increased, CD4 count is dropping, and the person is having some or the other clinical symptoms associated with labeling of failure, we do consider it as a failure of the therapy and we switch the person to the second line therapy.
Nous présentons la dernière recommandation et nous mettons l'accent ici sur qu'est-ce qu'il faut tester, les différentes recommandations en fonction de la question, qu'est-ce qu'il faut tester, quand tester, quels sont les différents types de tests à faire et aussi les autres considérations qu'il faut avoir dans ce cas-là.
Now, for this patient, what we did was that this patient, when he diagnosed that he has a tuberculosis, he admitted that he has no adherence. So, first thing we did was we started his anti-tubercular therapy. Then I asked him to get the viral load and to please continue taking the good drug which he is already on. Counseled him and his wife that he needs to be taking all these drugs diligently and repeated the viral load after 3 months. The viral load ideally came out to be lesser, so I continued the therapy. But if the viral load had would been persistently high, and in case you have a testing available, you can go opt for it. Otherwise, you upfront switch to the second line. And most of our regimes in second line are incorporation of the protease inhibitor. That is lopinavir, darunavir, and both with the ritonavir boosted regime. So in that scenario, we omit the integrase inhibitor and we introduce the protease inhibitor.
Revenons sur le cas du joueur de cricket dont nous parlions plus tôt, qui a reconnu qu'il ne suivait pas le traitement qui lui avait été donné et qui a développé des risques de tuberculose. Donc, le conseil a été de l'amener à continuer le traitement et de faire une autre évaluation après quelques temps. Et au vu de cette évaluation, le taux viral a baissé, ce qui pousse à continuer le traitement. Si le taux viral n'avait pas baissé et qui était resté assez haut, on aurait procédé à une autre série de traitements qui sont listés sur l'image ici.
And then there is a new advancement in the whole therapy. So talking on a good note, I would say now the word HIV cure is not something a distant dream. So we have now the therapies which are well advanced in terms of single pill. We have 3-month injectable maintenance regime. We are now coming up with 2-drug therapy, and amongst my patients, I have already initiated 2-drug therapy in almost 670 patients. Currently, I am catering to, in my hospital, in my cohort, I run an HIV clinic, which is comprised of 2,300 patients in last 4.5 years from different districts across my state. And recently, it's not too recent, but the cure of HIV in terms of the stem cell transplant, though it has not been medically approved for a particular this condition, but it was a blessing in disguise or a serendipity that based on the stem cell transplant being done for the other malignant condition, the person's marrow has to be knocked off and the CCR5 and CXCR4, which is the entry receptor of the HIV, they got double mutated. And eventually, when the whole marrow was replaced by some other donor, they found out to be that the bone marrow, which is the most hidden and the occult site, was free from the HIV RNA and the load for the consecutive 1 year. And then they were declared free from HIV. So far, almost 8 patients up to the date have been cured from the HIV. Even we did 2 bone marrow transplants of the people with HIV and 2 important conditions, one Hodgkin's lymphoma and the other was AML. Luckily, the AML with the HIV is still surviving and she's doing well. Whereas the Hodgkin's lymphoma recently got expired because of some opportunistic pneumonia, and he expired recently. But there is a ray of hope in terms of the HIV cure. So, HIV is not only the human immunodeficiency virus. Nowadays, I say that HIV is all about a hope and high cure rate. I means identify and investigate, and V is vigilant monitoring. So, with these 3 background, a good therapy, a good doctor, and a good patient compliance, and a very good family support, HIV cure and people living with HIV with the normalcy of the life is not more a distant dream. So
Enfin,
in that note,
nous terminons sur une note plus ou moins positive en nous penchant sur la recherche liée aux guérisons potentielles du VIH, telles que la thérapie par cellules souches ou l'édition de gènes. Et toutes ces méthodes soulignent le progrès réalisé et qui pourrait amener à une éradication du virus. Et on a recensé jusqu'à présent 8 personnes qui ont été guéries du virus. Donc, l'espoir est de mise.
Supriya, do you want me to continue and take up the tuberculosis, or should we, in the paucity of time, discuss some queries and questions from our doctors on the HIV?
Ma'am, we can start the question answer session. Maybe we can organize one more webinar where you can discuss about TB.
Sure. So I'm stop sharing the slides. Thank you so much for your patient listening about the HIV regime. I tried to cover as many aspects of HIV with the help of the clinical case scenarios, and I am glad to take up the queries and the questions.
Doctors, if you have any questions, you can either write it in the chat box or you can just turn on your mic and ask.
I think, okay.
Dr. Neha, there were some questions on the Google form that we circulated. So Dr. Emanuela has asked, what are the early signs of HIV?
Right. So, a good question, I would say. So, the early signs of HIV, or what we called as the HIV syndrome, acute HIV syndrome, like any other viruses, it's more like a flu-like symptoms. So, the person have the fever, and usually it's not the first time. So, most of them, when symptomatic, they come up with the symptoms like on and off fever for 2 to 3 months, feeling fatigue or the weakness is there, loss of weight, loss of appetite, cough, cold, sore throat. People are falling ill more frequently when they are not used to fall ill before. Loose motions or diarrhea. So these are all the symptom complexes of the initial a month or two presentation, which we call as a acute HIV syndrome.
Dr. Manuel has asked why don't we use urine lamb test and stool test for all patients?
Right. So urine lipoarabinomannan, that is a LAM test, which is being reserved for the tuberculosis diagnosis. So, Dr. Emmanuel, a very well asked question, I would say, but it has been described and validated for a CD4 count of less than 100 only. So nowadays we have approached a dictum like a cryptococcal antigen testing. We have started adopting a urine lamp testing also, but it is very well imagined and understood that lamb is an antigen which comes into the urine when you have a high burden of the TB bacilli in the system. And because your CD4 counts are low, then only the urine washout happens, and there how you detect the lamb. So for extrapolating to the all patients will be a task, because the sensitivity and specificity is well based on the CD4 counts less than 100. Regarding the stool testing, I presume you're asking for the other opportunistic infections bar the HIV. So regarding the stool testing, it is importantly known that usually when you have an HIV with the high viral load, if you start with the naive therapy, stool is studded with the flora. You will have lot of normal flora, lot of candida coming up into the stool. So interpreting it and taking care in terms of the treatment consideration would be a little task in terms of the stool testing, specifically in the HIV population.
Dr. Kabongo has asked, are there any antiretrovirals that can have prolonged action for up to 3 or 6 months?
Oh yes, Dr. Kabungo. As I mentioned in one of my slides, the directly acting antivirals with the longer life, we have recently come across a good paper. There is a cabotegravir, which is a longer acting version of integrase inhibitor. And along with the nucleoside inhibitor from the family of efavirenz, there is a rilpivirine and dilavirine. So a combination of cabotegravir and rilpivirine, which was a wonderful trial, tango trial in HIV, that has shown that the combination of these two, the viral efficacy and the viral suppression can be long lasted for almost 3 months. And that is why I've mentioned in one of the slides that this has come big way in the maintenance therapy, that a one injection, which is intramuscular, and even subcutaneous formulations are also there. So one injection thrice, once in 3 months, can take up as a maintenance therapy a patients who are already doing well stable on the ART.
Yaovi, can you translate that? Dr. Kabongo is from DRC. He understands only French.
Sorry, Dr. Neha, can you please do a quick summary so I can?
Yeah. So I was mentioning that these kind of injections, that is cabotegravir and rilpivirine, and their combination is well sorted in terms of the longer acting therapy. Their half life is almost 24 to 26 weeks. So they have been well designed for the longer acting preparations, and they are given once in 3 months to take care of the viral load for the next 3 months.
Donc, ce type de traitement, ce type d'injections sont à courte durée. Donc, elles ont une efficacité de 3 mois pour un fonctionnement. Ensuite, il faudrait recommencer.
Dr. Abu has asked, at what stage can we diagnose opportunistic infections and how can we diagnose?
A great question, Dr. Rabio. So, when it comes to the stages, the WHO has simplified our task. They have given the stages in the term of the grade 1, grade 2, grade 3, and grade 4 based on the different kind of infection profile and a CD4 based staging. So, practically at any stage, you can diagnose the opportunistic infection. I'll give you just one common example. Many a times, the patient who lands first time into your OPD, being recently diagnosed as HIV, lot of them has a mouth thrush, oral thrush in their mouth, oral fungal infection. So that is usually considered as a grade 2. Sometimes they comes with the big lymph nodes, and we always get scared. Are they TB? Are they lymphoma? But eventually they come out to be reactive, which is called generalized lymphadenopathy in HIV, which is a stage 1. So the idea about the stage is that you can diagnose the opportunistic infection at any stage. You have a good WHO table being done for that. And sometimes opportunistic infection only indicates that the person is having HIV, for example, tuberculosis. Diagnosing TB, when you detect the viral load presence, we state that it's already in a WHO stage 3. And when we check further, the viral load is in the lakhs and CD4 is less than, say, 200 or 250. That's how you kind of prognosticate and stratify the risk group. As far as diagnosis is considered, it can be in three-way model. One is the clinical, of course, the symptoms and signs. Second, what organ of the body is involved. And third, the targeted sampling. So, for example, in the case which I have presented, the person came up with the fever, cough, and bloody sputum. So, we tested the sputum sample for the nuclear testing, that is gene expert, and this is how we diagnose the tuberculosis. For an oral thrush, it is very clinically being diagnosed. For the other infections, so many times we do have cryptococcal meningitis as one of the a good opportunistic infection, or I would say HIV defining illnesses. There we do a CSF, and sometimes if CSF is not possible, serum cryptococcal antigen 2 to diagnose such conditions.
Uh, Dr. Neha, I think these are the questions that were there. If someone wants to ask any more questions, then you can turn on the mic and ask. Dr. Neha, if there are any more questions, I'll clap them and send them over to you over text.
Sure.
You can answer. So thank you for your valuable time and expertise. It was really an insightful session for us. Thank you.
Thank you all, and thank you for the patient listening, and thanks Jivo and Supriya for felicitating this. Thank you.
Yaovi, please stay back. I have an announcement to make.
Oh.
So doctors, we are going to organize an online OPD next week on Thursday. So you can look for 2 to 3 patients, who are diagnosed with HIV or TB, and you bring them to your clinic on Thursday. Then Dr. Neha will consult the patients on a Zoom meet. It will be a video consultation. It will be really helpful for your patients and for your medical tourism practice as well. So, before bringing the patients to your clinic on Thursday, just make sure to send their reports one day prior to the day of consultation so that we can make a case file and send them over to Dr. Neha. Yeah, yeah, you can translate.
Nous, nous aurons une séance de travail le jeudi prochain où vous pourrez venir avec vos patients qui souffrent du VIH ou de la tuberculose. Donc, vous pouvez les amener dans vos cliniques pour une consultation en direct avec Dr. Nia. Et il faudrait que vous envoyiez les rapports médicaux de ces patients un jour avant le jour de la consultation pour que la docteur puisse avoir une idée là-dessus. Merci.
Great from our side, Dr. Neha. Thank you once again.
Thank you. See ya. See you all.